Thank you. This is a very exciting time in epilepsy. There's a large number of new developments going on that are exciting, with exciting potential for future breakthroughs. They include the large amount of work being done in genetic epilepsies, in rare epilepsies, in detection of seizures with devices, but also with more standard treatments with medications. So there has been a lot of interest in research to find new medications for treatment of seizures. Epilepsy, as you know, affects roughly 3.25 million Americans, and roughly 1/3 of those are patients who don't respond to medications. And for those patients, the treatment options have been limited, so they include trying one of the 30 medications that are available, including roughly 20 that have been approved between 2000 and 2018, trying surgery, trying neurostimulation with RNS or VNS, trying dietary treatment with ketogenic diet. In the last 3 years, we've had 2 new medications approved that really seem to change the landscape of response of patients with refractory epilepsy to treatments. So we're going to be talking at the symposium about drug-resistant epilepsy, its impact on patients' lives, which is devastating, how the treatment landscape has changed since 2000, and then we're talking about whether one could, in fact, not only use the treatment to improve the lives of patients who've had epilepsy for 20 years, and as I've mentioned and keep mentioning, whose lives have been ruined by it, the drug-resistant epilepsy, but maybe use it earlier so that you can prevent that loss of quality of life. We now know how to predict whether a patient will develop drug-resistant epilepsy early on in the course of their disease. There are several indications that are pretty strong that tell us this person is on the path to developing drug-resistant epilepsy within 1 year of their first seizure. There are certain things that will tell that to us. The most important one, the strongest indicator, is if the patient has failed to respond to treatment with the first medication, regardless of which medication it is, because the medication lacked efficacy, not because of side effects. That's a different story. But if the patient fails to respond to one medication that has been adequately dosed and appropriately used, their likelihood of responding to second, third, fourth, 10th medication is maybe 11 or 12%, not high. And if they failed 2 medications, it's south of 5%. So there are other indications. Patients who develop epilepsy, who have depression, who've had a large number of seizures before they start being treated, are all patients who have a high likelihood of developing drug-resistant epilepsy. So the question that we're asking is whether it would make sense to use this treatment that appears so effective in the treatment of drug-resistant epilepsy earlier on, so that we can either suppress the drug-resistant epilepsy or prevent it by using it early in the patient's epilepsy path.